I want to go to our next slide as an intro. We're going to have these opening remarks addressing this interesting issue of death by cost sharing. We're going to hear next from Dr. Amitabh Chandra. He's a bunch of things. He's a professor of public policy and director of health policy research at Harvard's JFK School of Government. He's also a professor of business administration at Harvard Business School. He does a little teaching on the side and a bunch of other things as well. So Amitabh, it's great to have you in this very position. What in the world do you mean by death by cost sharing? Over to you, sir.
Wow, thank you so much, Cliff. It's, you know, I've been in this business for exactly 20 years. I've been a health economist for 20 years, and this is the first time that I got invited to come and present. So it's such an honor for me because I've been following in Mark and Mike's footsteps for 2 decades. I did not know the story about Kang. I think it's very appropriate that you all started at Kang. My Korean friends tell me Kang means strength, it means resilience, and you guys have been at it strongly and resiliently for so long. So I'm going to share with you a brand new paper that I did with my research assistant, Evan Flack, and with Ziad Obermeyer, who's a physician and data scientist at UC Berkeley. Next slide, please. And what we're going to ask is a very simple question. We're going to ask, you know, what happens to people's mortality when they face cost sharing? Now, for most economists, nothing happens to people's mortality when they face cost sharing. I think the standard view in economics is you face cost sharing, you cut back, and the cutbacks that one observes were wasteful care. But of course, I mean, I think most of us have always had the sense, most of us who are physicians, most of us who are sort of on the behavioral side of things, that like this cost sharing could harm patients if patients are cutting back in a very haphazard way. So if they're cutting back on a haphazard way, it could be the case that they cut back on very valuable medicines, in which case the spending that we, you know, the less spending we have, the savings are actually not the savings we wanted because we've harmed lives. There's lots of reasons to think that people don't know what to cut back on. I mean, if you think about just a simple math problem, we have a patient on 5 drugs. The patient faces cost sharing. What should they do? Well, the patient has to sort of figure out which is their most valuable drug, their second most valuable drug, their third most valuable drug. And there's 120 different ways in which you could rank 5 drugs, right? And the patient never went to medical school, not to mention that I don't think most physicians would know exactly how to rank these 5 drugs. So there is a growing literature on behavioral hazard. Back in 2010 with John Gruber and Robin McKnight, we found that very small cost sharing, just $5 or $10 of cost sharing, was causing patients to cut back on valuable drugs and land up in the hospital. We weren't able to look at mortality, and the response to our paper was, well, you're showing me that cost sharing gets people into the hospital, but they don't necessarily die, right, as a result of that cost sharing and that hospitalization. Nitish Chowdhury did really important work in the New England Journal of Medicine, where he looked at men with heart attacks and showed that, you know, for men who have just had a heart attack, so these are some of the most activated patients in the world, when confronted with cost sharing, they don't take valuable drugs that would actually prevent another heart attack. In some new work that I did with Zarek Brott-Goldberg, who is an assistant professor at the University of Chicago, Ben Handel and John Kolstad, who are economists at UC Berkeley, we found that when we move even high-income people into a high-deductible health plan, it does not look like they're acting the way economists thought they would be acting. For example, they're cutting back very haphazardly. They don't use any of the price transparency tools that we give people. So there was a sense, I think, that all of us had that the cutbacks that cost sharing induces might not be the cutbacks that we really want from a public policy point of view. Next slide, please. So then the question becomes, what about mortality? What about the health implications of cutbacks? And I think there's 3 reasons why we have not been able to do this quite as easily as we would have liked. The first is, it's very hard to study the effect of price increases on health because prices are not randomly assigned. So if you were to say compare people who fell into the donut hole in Medicare Part D to people who were just before the donut hole, it will look like the donut hole really kills you. right? But you have to be sick enough to fall into the donut hole. So is the donut hole really killing patients? Or is it that you were sick enough to experience a donut hole that was causing patients to have higher mortality? We don't know. So you need a design where patients are sort of being randomized into higher prices and lower prices. Mortality is also very, very, very rare, thankfully, right? So in our study, we're going to look at mortality in 65-year-olds. It runs at 1%. So 1% of 65-year-olds die every year. And to detect a 10% increase in that 1% mortality rate, I would need to randomize about 325,000 patients, right? That's a really, really big study. The treatment group in the Oregon Health Insurance Experiment was 9,000. In RAND from the 1970s, it was 5,500. So I think that's one reason we've always wanted to study mortality. It's very hard to study mortality. And so we've been studying cutbacks. And the problem with cutbacks is when physicians see patients cut back, they often say, well, it was high value care that they cut back on. When economists see patients cut back, we say, well, it was low value care that they cut back on. So the studying cutbacks in care is really a very crude, fairly insufficient, blunt way to get at what's going on with patient welfare, right? We want to know when you cut back, what's happening to your health. Next slide, please. So that's what we're going to do in this study. We're going to look at people who are exposed to the donut hole in Medicare Part D, not by comparing people who fell into the donut hole or who didn't, but for people who were randomly exposed to the donut hole by virtue of the month that they were born in. What am I talking about? Well, as many of you know, in your first year in Medicare Part D, when you're 65, the thresholds for the donut hole are not prorated by whether you joined in February or September or October. So someone who was born in February, enrolled in February, is much more likely to be exposed to the donut hole than someone who was joining in September. So that's what we're going to be working off of in this study. What do we find? We find that exposure to this donut hole, right, induces a pretty big price increase. We've known this forever, right? Prices go up about 30%, 33%. It's about an increase of about $10 per drug. What does it do? Well, it increases mortality by 30%. Now remember, baseline mortality is running at 1% for this group. They're all 65-year-olds in our study. So the 1% is becoming 1.33%. That's how you should think about this. Now, I think my economist colleagues on the call will say, well, maybe this was all rational. It would be rational if people were valuing their life at approximately $6,500, $7,000 per year. I think most people, most of the literature would say people tend to value their life somewhere between $100,000 to $150,000 per life year. So yes, you could square it with rationality, but you can only square it with a peculiar form of rationality where people just put a very, very low value on their lives. We find that patients drop life-saving medicines. So they're not just cutting back on drugs where we don't have good clinical evidence, but in response to these $10 copays, the drugs that people are cutting back on are statins, blood pressure meds, where we have very good RCTs that they will keep you alive. We see people in high-income zip codes respond identically to people in low-income zip codes. So this is not just a story about liquidity, this is a story about information. And interestingly, we find that about 20% of patients are more likely to just not be on any drugs. Now let's think about that for a second. We thought that patients would cut back on their drugs. If I'm on 5 drugs, maybe I drop to 4 drugs. If I'm on 4 drugs, maybe I drop to 3 drugs. And maybe I do that incorrectly. What we're seeing in the data, though, is people confronting this very complicated high-dimensional choice problem are sort of retreating from the choice problem completely and dropping to 0 drugs. Well, when you go from 5 drugs to 0 drugs, that's probably going to have really, really big mortality effect. So that's, I think, the behavioral driver behind it, is that there's some cognitive scarcity when people confront these very complicated, decision problems, and some patients just disengage. So, the takeaways, I think, are not that surprising for all of us in this room. Small changes in cost sharing generate very large mortality effects, which were probably not detected before, simply because no study in the past, be it RAND, be it Oregon, really had the kind of sample size to be able to detect this. We're not saying patients don't respond to prices, just to be very clear. We're saying patients do respond to prices. In fact, they're too responsive to prices. And I think that's that's a real opportunity for VBID designs, because if you can get them to respond to the right price, they will respond to the right price. I think that one of the things that we take away from our study is that there's a real opportunity for VBID, not only to put sort of high copays on some drugs and low copays on other drugs, but to have high copays for the patients who would benefit less for the drugs and low copays on the same drug for patients who would benefit more. So we roll out a machine learning algorithm that allows us to sort of ex ante identify these patients. And I think of it as this idea being much closer to the original formulation of VBID. VBID nowadays gets used a lot to say make preventive treatments free. But I think the real uses of VBID are to make the drugs that are really, really valuable very cheap, and make a variety of dubious drugs and dubious treatments quite expensive. And so I think we want to kind of go back to that original conversation at Kang Restaurant. Next time, maybe Mark and Mike, you will invite me to accompany you, because I think that conversation, which is now 20 years old, I think we finally caught up to you in terms of the machinery that's needed to get at the vision that you hatched 20 years ago. And thank you again to everyone for listening and for inviting me to this. The paper is in the public domain. You can download it at the NBR. Thank you again.
Amitabh, thank you very much for setting this up so well. And in particular, your takeaways are capital T takeaways. The aspect of large mortality effects, that caught my attention. And then kind of the nuance with regard to response or non-response to prices. But it really sets up a large or even larger role for VBID to identify which patients will benefit most. Again, I'm hearing echoes of nuance along the way there. So Amitabh, swell setup. We really appreciate it. We're going to bounce a few of your points off of our panelists later today. Thank you very much.
Thank you.
Okay.